Hello, good evening, everybody. Today's topic is psychosomatic medicine. I'm Dr. Tulika Shukla. I'm MD Psychiatry, and I'm working as a specialist psychiatrist at Millennium Medical Center, Dubai. The topic today, I would like to start, first of all, what exactly is psychosomatic medicine, followed by understanding, which is newer understanding of psychoneuroimmunology, psychoneuroendocrinology. Then we'll understand about what exactly are psychosomatic disorders and somatization disorders, conversion disorders, and some take-home points. So it is going to be a very brief run-through of psychosomatic medicine. It would be focusing more on the diagnosis and what are the presentations that people will come with, and what are the treatment strategies that we have so that people can come and avail treatments. So psychosomatic disorders are those in which mental factors play a significant role in development, expression, maintenance, or resolution of a physical illness, which basically means that mental factors are playing a very significant role in a physical condition. A physical condition like diabetes, like hypertension, is highly impacted by the mental factors. What is psychosomatic medicine per se? Psychosomatic medicine, it integrates interdisciplinary evaluation and management involving diverse specialties, including psychiatry, psychology, neurology, internal medicine, pediatrics, allergy disorders, dermatology, psychoneuroimmunology, and psychoneuroendocrinology. So all these factors are evaluated in a patient under the purview of psychosomatic medicine for a holistic treatment of a patient. So where does this concept come from? So initially, whenever psychological distress was associated with physical symptoms, it was considered in older psychoanalytical concepts as a symbolic substitution of emotional conflict. These ideas are obsolete now, and later we realized that this understanding came to be that emotional and physical stress are associated with a physiological response, and they produce a high adrenaline and high cortisol state. Following this, there was an even better understanding, a much clearer understanding of the physiological connection between stress, autonomic nervous system, and our immune system. This is basically studied under the branch of psychoneuroimmunology, which basically studies the impact of stress on the immune function system and the brain. Similarly, psychoneuroendocrinology studies the impact of stress on our hormone systems and the brain. So this is a good diagram which summarizes the mind-body connection. You can see that the central nervous system is where the functions of learning, memory, expectations are happening, and this is also the area where anxiety, stress, and depression is developing. Symptoms are coming from the central nervous system. And the pain perception of pain is also a very important function of the central nervous system. All of these are affected by our immune system, the vagus nerve through which the autonomic nervous system, and the neuroendocrine system. They are also closely working with our gastrointestinal system. So all these work together so this is a very good holistic diagram showing the mind-body connection, where all our bodily functions, our immune system, our autonomic nervous system, and our microbiome is affecting the central nervous system functioning. It will become more clear in the further slides what exactly this means. So if you want to understand psychoneuroimmunology, the brain as well as the immune system are two major adaptive systems in the body. They talk to each other, or they communicate to each other through, firstly, the HPA axis. If you have seen my previous presentations, I have talked in depth about the role of HPA axis in depression, in anxiety, in stress response. So the HPA axis and the sympathetic nervous system. This happens through an axis known as the sympathetic adrenal medullary axis. So we all know that the body's primary stress management system is the HPA axis, It responds to physical and mental challenges and maintains the body's cortisol levels according to the stress. If this axis gets dysregulated, which happens in many stress-related disorders, different kinds of stress responses can be seen. So basically, the type of response, the type of stressor, the duration of the stressor, acute versus chronic stressor, and the genetic makeup of a person, all three shape the HPA axis response, the regulation of the HPA axis and its dysregulation. What this basically means is that if there is a very severe stress, if there is a very long duration of stress, and if a person has a genetically vulnerable HPA axis, the dysregulation of HPA axis will happen and will lead to psychiatric disorders. How do the two interact with each other? How do the immune system and HPA axis interact with each other? The inflammatory cytokines, they stimulate ACTH and cortisol. Glucocorticoids that are secreted under stress, they suppress inflammatory cytokines. These are all technical names. Overall, these inflammatory cytokines and these pro-inflammatory cytokines are related to brain growth and neuronal function. So what will happen is, when there is a chronic increase in glucocorticoids and a chronic increase in the cortisol, they will affect the neuronal functioning. The evidence for this shows basically that these pro-inflammatory cytokines, they are elevated in many psychiatric disorders like depression, mania, and bipolar disease. The chronic secretion of stress hormone, glucocorticoid, and catecholamines are also known to reduce the effect of neurotransmitters. Neurotransmitters are chemicals in our brain which keep our brain functioning well, like serotonin, which is related to our mood, norepinephrine and dopamine, which are related to motivation and reward. All these functions can get dysregulated in case of chronic stress. So the abnormalities and the failure of these adaptive systems, the neuroendocrine system, and due to chronic inflammation, leads to behavioral changes, changes in the quality of life, metabolic as well as cardiovascular health. So if there is a chronic inflammatory stage and there is a chronic glucocorticoids are elevated and these inflammatory cytokines are elevated, it will also have an impact on a person's behavior. It will affect their quality of life, metabolic as well as cardiovascular health. This dysregulation creates a systemic anti-inflammatory feedback and hyperactivity of the local pro-inflammatory factors and contributes to the pathogenesis of the disease. This was shown by two large meta-analyses where they had shown that consistent immune dysregulation in healthy people occurs in people who are experiencing naturalistic stressors, like day-to-day stressors of life were affecting their immune functioning. The systemic neuroinflammation has also been implicated in many neurodegenerative disorders. So I just talked about that how inflammatory mediators affect neuron growth. So if there is a chronic state of inflammation, it can lead to worse neurodegenerative conditions like Parkinson and Alzheimer's, multiple sclerosis, and can also impact the pain perception. One very important thing to understand here is that our prefrontal cortex, the part of our brain which is involved in judgment, in decision making, in executive functioning, in motivation, is also regulated, which also regulates our psychological stress. So any processing that happens, any information that is given to us, it is processed by our prefrontal cortex. It is also directly controlling our vagal activity. The prefrontally modulated vagal mediated cholinergic inputs affects the splenic inflammatory response. So this axis of the prefrontal cortex, which regulates our autonomic nervous system, which regulates our spleen, is considered to be responsible for the immune dysfunction. Now that we have understood this biology, the understanding, how does this implicate in clinical practice? What do you see in clinical practice? This is all happening at cellular level. The course of many physical disorders is modified by stress. And if you don't diagnose the comorbid depression, anxiety, and you don't treat them properly, even the physical symptoms will not come under control. For example, these are some of the disorders in which the underlying psychiatric diagnosis has to be made and has to be treated. In dermatology, conditions like alopecia areata, neurodermatitis, psoriasis, musculoskeletal disorders like chronic low back pain and fibromyalgia, asthma, hypertension, and coronary artery disease. Hypertension studies have shown that almost 30% patients of hypertension have a comorbid anxiety or a depressive disorder, which needs to be treated. Similarly, gastroesophageal reflux disease, irritable bowel syndrome, peptic ulcer disease, they have a underlying anxiety or a depressive component which needs to be treated. PCOD, erectile dysfunction, vaginismus, dyspareunia, premenstrual syndrome, postmenopausal syndrome, they all have high psychiatric comorbidity which needs to be treated. Systemic lupus erythematosus and rheumatoid arthritis are other important immune disorders which have high psychiatric comorbidity. Similarly, thyroid disorders and diabetes mellitus. So, psychological symptoms, how are they connected to each other? I named a lot of disorders in which the importance of this page is that if any of these conditions are there, the doctor should look for psychiatric comorbidities. They should be screened and they should be treated. Otherwise, these symptoms will also not get controlled. You cannot get good control of GERD if the underlying anxiety disorder is not treated. Similarly, hypertension will not get controlled if the underlying stress and anxiety disorder is not treated. So a lot of times it is missed. The person is getting treated for hypertension, but the diagnosis of depression is missed. And then the person's hypertension is also not getting controlled. So that's the significance of these diagnoses. So what can happen? What are the presentations that can be seen in medical settings? Psychological symptoms that are clearly affecting a medical condition. For example, depressive symptoms affecting myocardial infarction, or delay in surgery recovery, or anxiety exacerbating asthma. Personality traits or coping styles can also affect a medical condition. For example, a person has a very serious medical condition which requires surgery, but because they are in denial, they may not be accepting proper treatment. Maladaptive health behaviors affecting medical conditions. For example, lack of exercise, smoking, unsafe sexual behavior, overeating. Despite having a medical condition like obesity, the person is not able to manage their eating patterns, or they know that they have diabetes, but they are not making the changes that are needed. Stress-related physiological response affecting general medical conditions. For example, like I just mentioned, the peptic ulcer disease, hypertension, tension headache, migraine, they are all highly affected by stress. Other than this, depression is an independent risk factor for development of coronary artery disease. So if somebody has depression and their depressive symptoms are not controlled, they are at a higher risk of developing heart problems. Similarly, mortality rates are also higher in untreated depression in cases, so in MI. Other than this, functional disorders, functional gastrointestinal symptoms, are almost 50% of gastric symptoms have a functional component to it. And irritable bowel syndrome is the most common diagnosis that is a most common psychosomatic disorders in gastrointestinal clinics. This was about the immune functioning and how the somatic symptoms, the physical symptoms might be manifested by an underlying psychiatric, might be getting affected by an underlying psychiatric problem. A lot of hormonal disorders also have a lot of high comorbidity, psychiatric comorbidity. So the clinical study of hormone fluctuations and their relationship to human behavior is known as Psychoneuroendocrinology. Certain mood disorders are associated with neuroendocrine and hormonal changes which affect the brain. Most common are the thyroid disorders. Thyroid disorders are highly correlated with mood disorders like bipolar disorder, depression, and cognitive impairment. So people who have hypothyroidism will very commonly present with depression. They can present with anxiety disorders, and they can even present with memory problems. Similarly, hyperthyroidism can present with anxiety, irritability, and personality changes. Obesity is also a metabolic condition where stress-induced eating plays a very important role, and underlying binge eating disorders have to be treated. Coming to premenstrual syndrome or PMDD, it is a mood disorder which occurs in the late luteal phase of menstruation and remits within first day or 2 days after the onset of menstruation. The symptoms are depression, irritability, anxiety, insomnia, bloating, breast tenderness, cramping, and headaches. Almost 5 to 9% of women in the childbearing age fulfill the criteria for PMDD. And in some cases, there might be a diagnosis of PMDD. In some cases, there might already be an anxiety or a depressive disorder, and there might be a menstrual magnification that just in the premenstrual period, the worsening of the mood symptoms happens. The treatment is hormonal OC pills, antidepressants. They can be given continuously or only in the late luteal phase, symptomatically to manage the PMDD. Intake of caffeine, salt, alcohol, and nicotine should be controlled during this period. Sleep hygiene measures, exercise, relaxation therapy, and CBT can be used for milder symptoms. Similarly, PCOD is also associated with higher risks of depression, anxiety, bipolar disorder, and OCD. It is associated with worsening of symptoms. If somebody already has depression, anxiety, OCD, or somatization, the worsening can happen in a person with PCOD. And the most important thing is to screen for these disorders. And then if it is needed, start an early intervention. Coming to another very important aspect of psychoneuroendocrinology are the postpartum disorders. Immediately after delivery, these presentations will be seen. Almost 85% women experience something called as postpartum blues. That is, in the first week after delivery, they might experience tearfulness, mood lability, irritability, and anxiety. They will peak around 5th to 7th day postpartum, and they will remit on their own within 2 weeks. So no treatment is needed for postpartum blues, but a person should be aware that around 1 to 2 weeks after delivery, almost 85% women experience these symptoms. They are self-limiting. They do not need any medication, but then the doctor must be aware of these things in the postpartum period. Another issue, another more serious issue that can happen is postpartum depression, which is a full-blown major depressive episode following childbirth. And this will happen in the first 4 weeks postpartum. To be called as a postpartum depression, it should happen within the first 4 weeks postpartum. And it can, if there has been a previous history, if a person already had a depressive disorder, they are at a higher risk. The treatment is the same as depression, but a lot of times postpartum depression can be missed because a lot of symptoms can be mistaken for just general fatigue and general anxiety about all these new things that have happened in life. Importance is the awareness about these conditions. A much more rarer but more serious form of postpartum illness is psychiatric illness is postpartum psychosis, which is also known as puerperal psychosis. It is very rare, relatively, 1 to 2 per 1,000 women. The onset will be abrupt. So around 2nd day of pregnancy, the psychotic symptoms will start appearing. There will be mood lability. The patient would be agitated, confused. There will be disorganization of thoughts. There can be hallucinations, paranoid delusions, sleep disturbances. So if it is seen that around 2nd day of delivery, a patient experiences this kind of a disturbance, it needs to be immediately treated. The risk factors here, if the person already has a diagnosis of bipolar, family history of bipolar, and any previous similar episodes, these are the high risk conditions. The important thing to note here is that the person needs to be hospitalized. If postpartum psychosis happens, the person needs to be hospitalized, and treatment is needed with mood stabilizers, antipsychotics, and supportive medication. So we have considered important psychiatric disorders where your immune systems and your hormonal systems play a very important role in the presentation of psychiatric symptoms. There are certain disorders where psychological conflicts or emotional distress can present as physical symptoms. There are two groups in the classification systems that we study. One is of somatoform disorders, and the other one is of conversion disorders. They are a very common, the presentation will be with physical symptoms, but the treatment will be psychological. The cause for the symptoms is psychological. So let's understand this in a little more depth. The DSM-5 classifies somatoform disorders or somatization disorders into the following: conversion disorder, somatization disorder, hypochondriasis, body dysmorphic disorder, pain disorder, and undifferentiated somatic symptom disorder. What is important to understand here is that there has been a rearrangement of these disorders according to the newer classification systems, but in concept, they stay the same. I will discuss conversion and somatization later. I will briefly talk about hypochondriasis. Hypochondriasis disorder is when there is a very excessive concern about having a physical illness. The person gets repeatedly evaluated, and despite being reassured that you do not have a medical issue, the person is still anxious about what diagnosis they have. They may or may not actually experience physical symptoms, but they are very preoccupied. So the word hypochondriasis has been removed from the current classification systems. Now we use the word illness anxiety disorder, because that explains it better, that they have an anxiety about having a physical illness despite all tests repeatedly coming negative. What will the person present with? The person will present with a lot of repeated investigations, unnecessary investigations, going to multiple doctors repeatedly, one doctor, and they're not satisfied because they are basically having a lot of anxiety. The other disorder here is body dysmorphic disorder, BDD. Here the preoccupation is that some part of their body is not shaped properly. It is dysmorphic. Although they have repeatedly been explained that it is not the case, but they are constantly preoccupied with the shape of their body, particular part of their body. It can be about their nose. It can be about the other parts of the body. Pain disorder, somatoform pain disorder, are disorders in which, despite repeated investigations, people have not been able to find a medical cause for the pain. The person, for example, chronic low back pain, you have got multiple MRIs done, you do not have any neurological or any orthopedic problem, but the low back pain persists. It has been found that low back pain, chronic low back pain, fibromyalgia, chronic fatigue syndromes are all pain disorders which have a very strong somatoform component to it, and the treatment cannot be just done with pain medications. So this is the new classification system I talked. So now the classification system somatic symptom disorder has included somatization and hypochondriasis that I just explained. Illness anxiety disorder is basically your hypochondriasis, which does not have any physical symptoms. Factitious disorder is another group of disorders where there is voluntary production of symptoms. What is very important to understand in somatization disorders and conversion disorder is that there is no voluntary production of symptoms. The patient is experiencing the symptoms. They are not doing it on purpose. In factitious disorders, the symptom generation is on purpose, and it is being done because the patient cannot directly ask for emotional care, and they want to get care from the medical facility. So factitious disorder and malingering are not somatoform and not dissociative disorders. Somatoform and dissociative disorders, the patient is not producing the symptoms, the patient is experiencing the symptoms. It's just that physically and medically the symptoms are not being explained. Coming to somatic symptom disorder, like I just explained, there are multiple somatic symptoms lasting for at least 6 months. So if somebody is having somatic symptoms for 2 weeks or 3 weeks, they don't need to be diagnosed with somatic symptom disorder and started on medication and therapy. It will pass off on its own. But if it lasts for more than 6 months, then it needs to be looked at. Similarly, medical test results are normal and they do not explain the person's symptoms. They have what is called as medically unexplained physical symptoms. History and physical examination do not indicate the presence of a medical condition. The patient is excessively worried about their symptoms. But the amount of stress they have about the physical symptom is out of proportion to the severity of the symptom. So for example, if a person has some headache, they're worrying about the headache they are so preoccupied about the physical symptom. That is where the dysfunction lies. And generally, somatic symptom disorders are associated with the presence of a significant psychological stressor. Generally, when you will interview the patients at depth, you will realize that there is something going on. There is some conflict going on at home. They are stressed about something, but at the same time, they cannot make the connection that their stress in the house is causing or stress in the workplace or the psychological stress is causing their physical symptoms. Coming to somatic symptom disorder, continuing the same. This generally starts during adolescence and the patients are diagnosed before the age of 30. This is seen across cultures and genders, and it is not the same as conscious malingering or factitious disorder, which I just explained to you. The treatment is with psychotherapy, CBT, where the person is taught to reduce their stress. They are taught to cope with their physical symptom. If there is a comorbid depression or psychological issue, that is addressed. The focus is moved to the quality of life rather than the loss of symptom. And the preoccupation with the symptom, the therapist works with the patient to reduce the preoccupation with the symptom. Brief psychodynamic interpersonal therapy can also be done in such cases, and antidepressant medications have also shown to work well in this diagnosis. This is the model of how the psychological stressors affect the psychoneuroendocrine network, and the person's personality, genetic factors, and environmental factors, they all interact with each other and give rise to the physical symptom. Lastly, discussing dissociative and conversion disorders. So dissociative disorders involve a problem with memory, identity, emotion, perception, behavior, and the sense of self. So how is somatoform disorder and dissociative disorders different from each other? Somatoform disorders, there is a physical symptom that the person wants to be addressed, will come with a physical symptom. In dissociative disorders, the problem will be in these functions, will be in some brain function. For example, they will have memory problem. When I say memory problem, it would be more like they have complete amnesia for the traumatic experience. They will have a different identity, which is a very rare disorder, dissociative identity disorders. There might be a dissociation in terms of their perceptions might be. So they may have a dissociative pain disorder. They may have, so basically the 3 to 4 common dissociative presentations that we see are dissociative seizures or pseudo seizures, dissociative amnesias, and depersonalization and derealization disorders. What are these? How will these symptoms? How will the patient come to you? What will the patient report? Depersonalization is where the patient will report that they have a feeling of being outside themselves and they are observing their action or feelings from a distance. They will say that the world is unreal and the people around them are lifeless or foggy. Depersonalization and derealization can both happen together. Dissociative amnesia, like I said, there will be dissociative amnesia for periods where they cannot remember information about themselves or events in their past life. They may also forget a learned talent or skill. There will be gaps in memory, which are much more severe than normal forgetfulness. And it cannot be explained. So basically, when amnesia or memory disturbance is associated with a brain disorder like dementia, the presentation will be very different. Here, there will be loss of memory for a very specific traumatic experience or a problematic experience in their life. Sometimes people may travel to strange places while they have dissociated. They may have blank episodes which can last, and these dissociative episodes can last for a few minutes, they can last for hours. They can also be associated with abnormal seizure movements or a dissociative paralysis, where the paralysis doesn't fit into the neurological presentation of paralysis. What is important here to understand is that these disorders are not, the patient is not pretending. The patient is experiencing these symptoms. The symptoms will not coincide with the neurological presentation of these disorders. And once you start asking for what has been the experience of the patient, you will generally find a traumatic experience which has led to the physical symptoms. So it is more like a shock reaction. The person is in shock. Similarly, dissociative identity disorder are there, which is also known as multiple personality disorder. The patient may feel the presence of other identities, each with their own name, histories, and mannerisms. The memory gaps will be there about their everyday events and personal information, and they may have several distinct identities. Dissociative identity disorder is a relatively rare disorder. In its full-blown form, DID doesn't happen. What is more commonly seen in dissociative disorders is pseudoseizures and dissociative motor disorders, paralysis. So what are the take-home points with today's presentation? Firstly, the chronic stress produces physical symptoms by impacting our immune system and hormone systems. Many chronic medical disorders like coronary artery disease, hypertension, diabetes mellitus, obesity have high psychiatric comorbidity, which needs to be identified and treated. Many neurological, endocrinal, and autoimmune disorders present with the psychiatric symptoms which need to be treated. And psychological stressors can present as medically unexplained symptoms or functional symptoms or dissociative symptoms, and they require proper treatment with a mental health professional with medications and therapy. With that, I conclude my presentation.